Hello everyone, welcome to another episode of Clinical Case Discussion. This is episode 5 of thyroid swelling. So, in this video, we are going to see mainly the management of thyroid swelling. So, let's just briefly review about the provisional diagnosis that it contains three components: anatomical, functional, pathological. The moment you say this about this provisional diagnosis, the exam will start asking the questions retrogradely with each component of provisional diagnosis. The first thing that can be asked by the examiner is, how do you say or why do you say it is a thyroid swelling? So why thyroid? Why not something else? So there are mainly three or four important cardinal features to say it is thyroid swelling. First one is anatomical location. Anatomical location of the swelling within the thyroid region or thyroid fossa. Then the examiner will ask you what are the boundaries of thyroid region, which we have discussed in last video. Okay. Second one is the swelling is moving up with deglutition. So movement of swelling up or upward movement of swelling with deglutition. That is the second point you should tell. Then the exam will ask you two or three important questions related to this point. One is, why does thyroid swelling move up with deglutition? We have answered that in the previous video. And what are the thyroid swellings which will not move up with deglutition? That is another point that you should remember regarding this second entity. So the third answer you should tell is that it is present deep to deep fascia. Then the examiner will ask you, why do you say that thyroid swelling is present deep to deep fascia? So you need to tell two important points. One, by stretching the fascia, the swelling is becoming less prominent. Second point is, as the swelling is moving up with deglutition, it indicates that the swelling is present deep to the deep fascia. And very rarely, and lastly, you should tell if it is something like a bilateral thyroid swelling that is very conspicuously enlarged, then it will take the shape of thyroid gland. That is nothing but butterfly shape. This last point should be told only if it is something like involving both lobes of the thyroid gland. So these are the 4 points that you should remember to answer the question, why thyroid swelling or how thyroid swelling or how do you justify it is a goiter. Okay, so that is the important thing that we should remember. Next, coming to the four cardinal signs of primary toxic goiter. This is a very important entity commonly asked with examiners. So first one is, you can see here in the primary toxic goiter there will be thyroid ophthalmopathy, right? Nothing but exophthalmos. Then you have got a goiter, nothing but thyroid swelling. Then when you palpate the pulse of the patient, there will be obviously tachycardia. So there will be tachycardia. That is the third point you should remember. Last one is tremor, hand tremor. I told you it is related to your hypersensitivity of the free nerve endings caused by the increased level of thyroid hormones. Okay, so these are the four cardinal features of primary toxic goiter we need to remember. Right, next. So coming to the management part, I told you management always includes two things: investigations and treatment. Again, investigations are divided into routine investigations, specific investigations. Specific investigations are subdivided into lab, imaging, and pathological and others. Okay, right. So first one is routine investigations. You know that as a part of every single inpatient, if you are going to do a major surgery, we need to have a list of routine investigations. And coming to specific investigations, the first and most important is thyroid profile, which contains TSH, T3, and T4. Please understand, out of these three things, TSH is the most important one, right? Another one is serum calcium. It is very important, and when you are planning for total thyroidectomy in case of bilateral MNG or in case of even malignancy, right? Next, especially if there are any associated features of calcium disturbance, right? Next one is serum thyroglobulin along with the anti-thyroglobulin antibodies. This is not done as a part of preoperative workup, but it is most important in case of post-operative follow-up after total thyroidectomy for a differentiated thyroid cancer. So it is done in post-op period. So post-op follow-up, you will do this test. We will discuss that after the thyroid surgery operative part. Right. Next one is coming to imaging. What are the important X-rays that we need before we go for thyroidectomy? Second one is high resolution ultrasound. Please understand, ultrasound is extension of clinical examination. So we need to go for high resolution ultrasound neck. Then thyroid scan or radioactive iodine uptake scan. Again, this is not done in all cases. We will discuss the indication subsequently. So next one is CT neck. Again, just like we discussed in parotid, there are only few indications for CT neck in case of thyroid swelling. Okay, we will see what they are. Next one is coming to pathological investigations. First one is FNAC. We have discussed in parotid that we don't go for biopsy because there may be chance of iatrogenic facial injury. Here also, except in very few conditions, we will not go for biopsy. FNS is the preferred pathological investigation. Biopsy is done in only three important conditions that we will discuss subsequently. Next one is you will send the patient to ENT department to go for video laryngoscopy, or sometimes they do even indirect laryngoscopy. So why is it important means to document the status of vocal cords in the preoperative scenario, so that you should rule out any if there is any asymptomatic vocal cord palsy is there or not. So it is to rule out asymptomatic vocal cord palsy. Why is it important? Because in 3 to 5% or less than 10% of the people, there may be asymptomatic vocal cord palsy. Means the voice of the patient will be absolutely fine. But when you have done VLS, there may be some unilateral asymptomatic palsy. There will be vocal cord palsy. And you need to document it properly. And if you explain the patient that there may be increased risk of hoarseness of voice after the surgery, if at all something has gone wrong in the surgery. Okay, so this is why it is important to document the most recent test regarding this particular voice and its complication with the thyroid surgery. We are going for something called audio recording. That means it is nothing but you will record the voice of the patient with an audio device, and you will match it with that after the surgery. So that is the latest advance that we need to remember, right? Next. So first one is thyroid profile. You know, there are mainly three components. One is TSH, free T4 and free T3. So these are the normal levels: zero point 0.3 to 3.3, 10 to 30 and 3.5 to 7.5. Okay, so what are the main different possibilities that we can have in the thyroid profile? So everything is normal means the function of the thyroid gland is normal, right? Let's say for example TSH has been increased and free T4, free T3 are decreased. Actually, it will happen in the negative feedback mechanism. It means that T3, T4 when they are decreased, it will give feedback mechanism to hypothalamus as well as anterior pituitary to increase the thyroid stimulating hormone levels, so that there may be increase of T3, T4, right? So based on T3, T4 there will be response of TSH. So it indicates that there is primary hypothyroidism. Okay, nothing but clinical hypothyroidism. Let's say for example rarely you can have there is rise of TSH, but free T4 and free T3 are normal. So this is something nothing but your subclinical hypothyroidism. Okay, so this is subclinical hypo. Let's say for example TSH is decreased and free T4, free T3 are increased. This is nothing but hyperthyroidism, thyrotoxicosis. Okay, next. Again, you can have something like you know there will be normal or little bit increased TSH, but free T4 is increased very much, and free T3 also more or less increased or normal. This is something called Refetov syndrome. What is Refetov syndrome? In few individuals, normally TSH receptor, wherever you have got a free T3 receptor, sorry. So you know that T4 is converted to T3 to act on the peripheral tissues. So this T3, whenever it is not able to bind, there is nothing but due to T3 receptor resistance. So end receptor resistance. So what happens now? T4 will be becoming more into T3. That means T3 will be increasing more and more. So T4 may be something like a mildly raised also. So body thinks that there may be decreased thyroid hormone levels. That is why TSH will try to compensate little bit. It may be little mild increase or it can be normal also. Okay. So this is the interpretation of basics of thyroid profile. Right. Next. Coming to X-rays. Please understand, undergraduates can remember what are the X-rays that are required. That is, one is chest X-ray PA view, X-ray soft tissue neck AP and lateral, and X-ray C-spine lateral view. But for PGs, they will ask you the explanation. Why do you require these X-rays? Okay, so you know that chest X-ray POV is basic requirement to look at the lungs because we are giving general anesthesia. It is more important for our anesthesia purpose, and also you can also check the whether there is any deviation of trachea or not. So you can also look at the trachea. Coming to X-ray soft tissue neck, again AP view is mainly for trachea deviation. Lateral view is mainly important for tracheal compression because in case of huge goiter in a prolonged time, it can compress the trachea. So you can observe for the tracheal compression in lateral view. Also, if there is any retrosternal goiter extension, you can take a note of it. So retrosternal extension of goiter. You can find it on lateral view. And coming to C-spine lateral view, why is it important? Because when you are doing the thyroidectomy, you are keeping the patient in rose position. That means hyperextension of the neck will be there. So to rule out any asymptomatic cervical spondylosis, you are going for X-ray C-spine lateral view. This is more important in case of symptomatic people or even in case of elderly people where there is more chance of cervical spondylosis. Okay, right. So these are the essential X-rays required in goiter. Now, coming to algorithm of solitary thyroid nodule. So, please understand whenever a patient presents to you with goiter, after proper history and examination, so the first and most important test you will be going for is serum TSH. Nothing but you will be sending for thyroid profile. In the thyroid profile, what is most important is TSH. Based on TSH, you will take the next decision. So let's say, for example, the patient has got a decreased TSH. What do you mean by that? It means that patient is in hyperthyroidism. So according to the protocol, you should go for radioisotope scan. So there is nothing but thyroid scan. You can use iodine 123 or even technetium 99. So there you will go for here mainly based on this thyroid scan. You have different types of nodules here. One is hot nodule. So second one is cold nodule. So first one is hot nodule, second one is cold nodule. So how do you differentiate that? We will see the images subsequently. So why is it important to do thyroid scan and check whether it is hot nodule or cold nodule? If it is hot nodule, obviously you cannot go for surgery. You need to treat that particular condition. You will identify the cause. Then you will go for either surgery after you treat that particular hyperthyroidism condition. Only when the patient is in euthyroid state, then only you can take up the patient for surgery. Okay, right. If it is something like a cold nodule, you can go for next part of the evaluation, or straight away if the TSH is normal or little bit elevated, that means patient is in mild hypothyroidism. The next thing you need to go for is high resolution ultrasound neck. Okay, so based on high resolution ultrasound, what are all the important points you should look in ultrasound? We will see that in subsequent slide. So based on that, you have got something called a thyroid score. We will see that in the next slide. So after ultrasound, you will decide whether this patient requires fine needle aspiration cytology or not. If FNAC is required, you will send the patient for FNAC. So based on FNAC, in FNAC you have a classification called Bethesda classification. Based on which class of Bethesda it is, there are 6 classes. So based on Bethesda class, you will go for next step, right? So in high resolution ultrasound neck, what are all the points that you should look for? It is most important for PGs, that is an additional point. But for undergraduates also, there may be a question like what are all the basic things that you can check for. One is organ of origin, whether it is really thyroid gland or not. Then echogenicity. I told you there are mainly 3 important types of echogenicity: hypo, hyper, then iso. So you can have iso. It is more of a hypoechoic or something like a heteroechoic, that is more suggestive of malignancy. So the question will be something like, how will you differentiate between benign versus malignant on ultrasound? So first we will see what are all the points we should check for. We will apply that to this question. Then site type. Where exactly in the thyroid gland you have got the pathology. Then size, borders, whether they are well defined, regular or not, etc. Consistency in ultrasound, you have mainly 2 things. One is solid, second one is cystic. Then vascularity, calcifications, and lastly but not least, cervical lymph nodes. Whether there are any subclinical cervical lymph nodes, you need to check. So we will apply these lines to benign versus malignant. So obviously you can have a little bit something like isoechoic or hyperechoic in benign, whereas in malignancy there will be heteroechoic, right? Next is regarding the size, one important point we should remember is taller than wider. Taller than wider. That is the classical finding in case of malignancy, right? Next is borders. Obviously, it will be irregular. Next is consistency. Usually, cystic consistency is more towards something like a benign condition. If it is something like a mixed variety or purely solid, it may be malignancy. Okay, right. Next is vascularity. Please understand, whenever you have got a swelling, if it is something like a increased central vascularity will suggest it could be malignancy. Whereas in case of peripheral increased vascularity, increased peripheral vascularity will suggest benign condition. So peripheral vascularity is increased means it is more of a benign condition. Okay, right. Next, coming to calcification, there will be something like a peripheral eggshell-like calcification, a rim of eggshell-like calcification. Whereas in case of malignancy, it is something like small multiple micro calcifications. Right. Next, obviously there will be enlarged cervical lymph nodes. So whenever there is lymphadenopathy present, you have to go for the next investigation is CT-MIC. According to the protocol, you should go for CT-MIC to check whether there are any again anterior mediastinal lymph nodes and other things that you can pick up in CT-MIC. So these are the important points regarding ultrasound neck. So for PGs, there are two important additional things that one should remember. So nothing but thyroid score. One is thyroid score. Just like we have got BIRADS for breast, we have got thyroids in thyroid, thyroid imaging, reporting, and data system. Here, there are mainly five important components you can remember with the help of mnemonics SESME. C for composition, E for echogenicity, S for shape, M for margin, then echogenic foci. So based on these each important component, depending upon whatever the positive findings that are present, there will be a total score, and based on that you have got thyroids 1, 2, 3, 4, 5. Just like we have got 0, 1, 2, 3, 4, 5. Here we have got thyroids 1, 2, 3, 4, 5. So based on thyroid score, you will go for FNSC if required. So if it is something like a benign entity, there is no requirement of any fine needle aspiration cytology. So if it is something like thyroids 2, 3, 4, 5, based on the size of the nodule, you will go for fine needle aspiration cytology. Okay, right. Then there is another important concept called resistance index. The question will be something like, how will you differentiate between whether the thyrotoxicity or nothing but increased thyroid hormone levels is because of a benign entity or a malignancy. So when you are doing ultrasound neck, you will do Doppler and you will calculate something called resistance index. If resistance index is less than 0.7, it is suggestive of a benign entity. Whereas if it is something like more than 0.7, it is suggestive of malignancy. So that something it will be like toxic goiter has got less resistance for the vascularity. That is why a benign entity will be having less than 0.7. Another a very broad thing that you can differentiate between benign and malignancy is if it is something like a generalized vascularity throughout the nodule or something like a throughout the swelling, if it is benign. Whereas if you see any areas of vascularity here and there, that will suggest malignancy. Okay, right. Coming to thyroid scan, this is also called radioactive iodine uptake scan. So we need to differentiate. There are mainly three important findings. One is warm nodule, second one is hot nodule, and another one is cold nodule. So warm nodule is something the nodule and the surrounding thyroid gland will have same uptake of technetium 99 or iodine 123. Hot is something that will take up more radioactive iodine than surrounding thyroid tissue. So you can see here, this is the hot nodule and this is something cold nodule. Okay, right. Next, cold nodule is something which will take up less contrast when compared to other surrounding thyroid gland. So here you can have this thyroid gland, and you have got here less uptake, that is nothing but cold nodule. Then this is a pyramidal lobe. This is hot nodule where there is more uptake of radioactive iodine. Then you have got Graves' disease where there will be diffuse, entire gland is involved. Okay. And another important point we need to remember is that warm nodule almost doesn't have any chance of malignant transformation. And cold nodules, you have got around 15 to 20% of cold nodules are malignant. Whereas in hot nodules, around 5% of hot nodules are malignant. Okay, so these are the important points we should remember. And what are the main indications for thyroid scan is that we have seen one is when you have done thyroid profile and TSH is something decreased. That means patient has got hyperthyroidism. Then another indication is whenever you have got ectopic thyroid, very most important is in post-operative period, post-op total thyroidectomy for differentiated thyroid cancer. For differentiated thyroid cancer. Okay, these are the main indications for thyroid scan. So we will see the post-operative scenario in the subsequent slides. Okay, right. Next, coming to FNAC, whenever you send the patient to FNAC, the report will become comprising of something called Bethesda classification. You have got 6 classes: 1, 2, 3, 4, 5, 6. One is inadequate or incomplete. That is why you need to go for repeat FNAC with ultrasound guidance. And coming to second one, you have got benign entity. As it is benign, you don't need to go for next evaluation. You just need to ask the patient to come for follow up. So you need to do clinical and sonograph follow up. Third one is AUS or FLUS, os or plus. Atypia of undetermined significance, follicular lesion of undetermined significance. Whenever you get this kind of a picture, Bethesda 3, you need to go for repeat FNSC. If you are in a sophisticated setup, you need to go for molecular testing. Or if you don't have that facility, you can go for lobectomy. Lobectomy is something like a Western literature for hemithyroidectomy. So in Indian scenario, we will go for hemithyroidectomy. So there is nothing like practically lobectomy. We will see what are the different types of thyroidectomy in the subsequent slides. Okay. So next, coming to 4, it is called follicular neoplasm. Okay. Again, if you have the facility, you will go for molecular testing, and if you don't have the facility, you will go for lobectomy. I mean hemithyroidectomy. Right. Next, coming to 5, it is suspicious for malignancy, and 6 is confirmed malignancy with the biopsy. Right. So the first 3 columns will be more important for undergraduates. For PGs, additionally, they will ask you percentage of malignancy for each class. At least we need to remember class 3 and class 4, where it is something like 10 to 30% for class 3 and 25 to 40% of class 4. There is nothing but follicular neoplasm. Another important question they will ask you is what are the disadvantages of FNAC in thyroid swelling? So, what are the pitfalls or disadvantages? The main disadvantages is that it cannot differentiate between follicular adenoma versus carcinoma. Why? Because we are just picking up the cells but not the tissue. So, in case of follicular carcinoma, there are mainly 2 important hallmarks. That is, one is vascular invasion, another one is capsular invasion. These are the 2 important things we should remember. These 2 important points cannot be assessed by FNAC. Only biopsy can tell you about vascular invasion or capsular invasion. So these are the 2 important points which FNAC cannot tell. That is why it cannot differentiate between adenoma and carcinoma. Okay. So these are the important points regarding Bethesda classification. And molecular testing is something like a recent advance. So they will be testing the particular specimen for genetic testing, and you can differentiate between whether it can be adenoma versus carcinoma can be picked up by molecular testing, right? But not only FNAC, right? Coming to biopsy, I told you usually biopsy is not done in case of thyroid swelling, but there are mainly 3 important conditions where you should go for biopsy. One is anaplastic thyroid cancer, which has got the worst prognosis. Then why are you making biopsy? To confirm that it is anaplastic carcinoma. Then another one is thyroid lymphoma, radial thyroiditis. In every case of radial thyroiditis, you need to go for biopsy because the clinical findings of the radial thyroiditis will be very hard. You can't differentiate, you cannot tell whether it is really thyroiditis or malignancy. It will be that hard. That is why you should go for biopsy to rule out either lymphoma or anaplastic thyroid cancer. Okay, next. Frozen section just now I have discussed. What is the main role means? Whenever you are doing hemiathorectomy in case of Bethesda class 4, you will send the specimen to frozen section. If frozen says, if it is something like frozen section is negative, you can close, like finish the surgery. Then if it is something like positive, you need to go for total thyroidectomy or near total or total thyroidectomy. Okay, right. Next, so these are the different types of thyroid cancer you have based on cell of origin. You know that there are mainly two important types of cells in thyroid gland. One is follicular cell, second one is parafollicular cell. So from the parafollicular cells, you will get calcitonin. You know that. So from the parafollicular cells, you have medullary thyroid cancer. From follicular cells, again, well differentiated thyroid cancer and undifferentiated thyroid cancer. I told you anaplastic carcinoma has got the worst prognosis. Whereas differentiated thyroid cancer has got good prognosis. Again, this well differentiated has got three types. One is papillary, follicular, Hurthle cell carcinoma. Hurthle cell carcinoma is nothing but it is a variant of follicular carcinoma where you have got oxyphil cells or Hurthle cells in the microscopy. Okay, so the prognosis for differentiated thyroid cancer is good. Coming to for fine needle aspiration cytology, when you send for FNAC, there can be few findings that will suggest that this could be the malignancy type. So you need to remember three P's. One is Samama bodies. Second one, pale empty orphan nuclei. This is the pale orphan nuclei. So then other one is papillary projections. You can see here, these are the papillary projections. These are the three P's of papillary carcinoma thyroid. Okay, now this is something like a diffuse well strained area, that is amyloid stroma. Where will you get amyloid stroma? It is nothing but your medullary thyroid cancer. Medullary cancer. Okay, so these are few important microscopic findings that you should remember. Coming to thyroidectomy, please understand nowadays we are mainly following, if you have this thyroid gland, if one entire lobe which is pathological and also including complete isthmus, we if you remove that, that is called hemithyroidectomy. Okay, so lobectomy is something like a western literature. In Indian scenario, we will go for something called hemithyroidectomy. Okay, so total thyroidectomy is entire gland is removed without leaving anything. And there are two other important terminologies that you should remember. Subtotal thyroidectomy is nothing but you will remove both sides, leaving around 8 grams of thyroid tissue. So just remember the numbers: 8 grams of thyroid tissue in the tracheoesophageal groove on both sides. Then coming to subtotal thyroidectomy, and that is, I mean, there is something else called Dunhill procedure, where it is also called near total thyroidectomy. You will remove entire thyroid gland, but you will leave except around 1 to 2 grams of thyroid tissue will be left on the opposite side, and you will remove rest of the thyroid gland. That is called Dunhill procedure or near total thyroidectomy. Right? Next. So this is the picture that is given here. Please understand regarding the operative surgery part. One important question the examiner can ask you is, what is the minimum surgery if you want to go for operative operation? What is the minimum surgery for a thyroid disease or minimum biopsy for a thyroid gland disease? Please understand the answer is hemithyroidectomy. Then the examiner will ask you, let's say for example you have got a small nodule in a single lobe of the thyroid gland. Why can you not go and remove only that particular nodule? Why are you going for hemithyroidectomy? Please understand, surgery of choice for hemithyroidectomy is, I mean, sorry, surgery of choice for a solitary thyroid nodule is again hemithyroidectomy. So the examiner will ask you, why is hemithyroidectomy the minimum surgery or biopsy, or why is it the surgery of choice in case of solitary thyroid nodule? Why can you not go there and simply remove only that particular nodule? You need to understand in thyroid gland, The main most proliferative part will be at the isthmolobar junction. So, if you leave only that nodule, there can be again more chance of recurrence from the isthmolobar junction. So, the answer will be something like isthmolobar junction. Okay, so you should answer like around 40% of the solitary thyroid nodules are thyroid adenoma, and the adenomatous transformation of solitary thyroid nodule will begin at isthmolobar junction. That is why in hemithyroidectomy we will be removing one entire lobe which is pathological and also complete isthmus. So this is right hemithyroidectomy. So that is the explanation why hemithyroidectomy is the minimum surgery or biopsy. Then I told you subtotal thyroidectomy, you will be leaving around 8 grams of tissue at tracheoesophageal groove. And total thyroidectomy, please understand whenever you are going for total thyroidectomy, you should preserve parathyroid glands. We will see what happens if you accidentally injure either parathyroid glands or the vascular supply to the parathyroid glands. Okay, now so total thyroidectomy in differentiated thyroid cancer. Again, undergraduates can skip this slide. So it is mainly important for PGs. What are the important indications to go for total thyroidectomy in differentiated thyroid cancer? So mainly it is at least the size of the tumor is 4 centimeters. Extrathyroidal extension is present. Then evidence of any metastasis. Radiation induced differentiated thyroid cancer. That means in a prolonged duration where previously the patient was exposed to radiation and now the patient developed differentiated thyroid cancer. Most common one is papillary. In such scenario also you should go for total thyroidectomy. Then familial non-medullary thyroid cancer. So if it is not a medullary cancer but there has been positive family history, you need to go for total thyroidectomy. Then multifocal or bilateral multifocal or bilateral differentiated thyroid cancer, again you need to go for uh, total thyroidectomy. These are the important scenarios of high rate of recurrence. That is why you are going for total thyroidectomy. Otherwise, you can go for hemithyroidectomy based on the scenario. Right now, coming to the operative surgery part, please understand for undergraduates or even for postgraduates, in the final practical viva, they will ask you about the steps of thyroidectomy. So please understand any operative procedure can be remembered or understood with the 6 headings. I for indications and contraindications, A for anesthesia, P for position, I for important steps, C for complications, P for prognosis and follow-up. Right? So the mainly what are the indications for thyroidectomy? It depends on condition that you are going for. What type of thyroidectomy is essential. And coming to contraindications, please understand whenever you want to go for thyroidectomy in thyroid disease, patient must be in euthyroid state. Patient shouldn't have either hypo or hyperthyroidism. Why? What happens if you take up a patient of hypothyroidism to surgery? Patient will land up in something called myxedema coma. That is the complication you may expect. And if the patient is in hyperthyroidism, you have not prepared the patient properly, and if you take up the patient for surgery, patient may land up in something called thyroid crisis, which is also called thyroid storm. We will discuss it in a completely different video. So please understand, patient must be euthyroid before you take up the patient for surgery. And other contraindications can be, I told you thyroidectomy is done in under general anesthesia. Whatever the contraindication to general anesthesia, that is also an contraindications for thyroidectomy, right? So I told you the anesthesia is nothing but general anesthesia, and the position of the patient is rose position. Then we will discuss the operative surgery important steps. Then coming to last one is complications. Okay, right. So the first one is indications. Please understand, based on I told you there are mainly around three important thyroidectomies that we are following these days. So one is hemithyroidectomy, then another one is subtotal, last one is total. So hemithyroidectomy is usually done in solitary thyroid nodule. Another important question they can ask you is, what are the important pathological conditions of thyroid which can clinically present as STM? So what are the important conditions? or they can ask you what is the differential diagnosis of solitary thyroid nodule. Please understand, one is adenoma, thyroid adenoma. Then second one is colloid goiter, or it can be dominant nodule of MNG. Okay. Then another important is thyroid cyst. Then you can also have small size differentiated thyroid cancer. Okay. These are some important conditions, pathological conditions, which can clinically present as solitary thyroid nodules. So whenever you have got these uh, as the FNAC impression, you can go for hemorrhectomy. And the subtotal is usually go for, we will do it in multinodular goiter. If it is something like MNG is present in both lobes almost, then you will go for total thyroidectomy. And also it is done in malignancy based on what type of malignancy we are dealing with, right? So these are the basic indications. Coming to position, I told you it is nothing but rose position, where the neck is something like a hyperextended. Both head and neck are hyperextended, and we will keep the patient reverse Trendelenburg 30 degrees, reverse Trendelenburg 30 degrees head and up. Why? To reduce the venous congestion in the surgical field. And you will keep a soft pillow below the shoulders, as well as a head ring, as well as a head ring under occiput, right? So this is the classical rose position, which is also used in tonsillectomy. Okay, right. So coming to thyroidectomy procedure, please understand the first one is nothing but your incision. We'll write down the important flow chart. First one is incision. Please understand it is also called Cocker's incision, which is also called cervical collar incision. Cervical collar incision. Where is it extending from? So you will start at posterior border of one sternocleidomastoid muscle till the posterior border of opposite side sternocleidomastoid muscle. Okay, we'll start at the posterior border of sternocleidomastoid till the opposite side sternocleidomastoid. This is the classical Cocker's incision, which is also called cervical collar incision. You will make the incision 2 centimeter above suprasternal notch. That's where you will make the incision. Okay, right. After the incision, the main thing you are doing is you are raising the flaps at the level of platysma muscle, just beneath the platysma muscle. So that is why the second step is subplatysmal flaps. Here you need to understand where will we raise the flaps till. Superiorly, you will raise the flaps till the superior border of thyroid cartilage. Inferiorly, you will raise the flap till the suprasternal notch. So you need to remember superior and inferior. Where will you raise the flaps till? Okay, superiorly superior border of thyroid cartilage, inferiorly suprasternal notch. Once you raise the flaps, now you can take the help of this diagram. We need to remember this diagram. So after you raise the flaps, you will be visualizing something called investing layer. So you will make an incision over the investing layer in midline vertical incision. So you'll make an incision something like a midline vertical incision like this at the level of investing layer of deep cervical fascia. So midline vertical incision. After that, once you open the investing layer here, what is the next thing you are going to see? They are nothing but your strap muscles. So please understand, usually if it is something like a hemithyroidectomy or a small goiter, you can go for retraction of the strap muscles. In very rarely, if it is something like a very huge goiter, with a simple retraction, you are not able to see the goiter properly, swelling properly. Then you need to go for cutting of the strap muscles. We will see that in subsequent slide. So once you retract the strap muscles, you can see here in the picture, the next layer is pretracheal fascia. So you will open pretracheal fascia. Once you open the pretracheal fascia, the next thing you are going to hold is nothing but your thyroid gland. So once you encounter the thyroid gland, what is the next step? So before that, we will see What are the indications to cut strap muscles? I told you, if it is something like a very huge goiter where you are not able to visualize the thyroid gland properly with simple retraction, you will go for cutting. So if at all you need to go for strap muscles cutting, where will you cut? Means, is it in the superior aspect or is it in the inferior aspect? So please understand, you will cut the strap muscles superior aspect. Why superiorly? So the explanation is because the nerve supply, let's say for example you have got strap muscles like this, the nerve supply of strap muscles is something like a below upwards, like this. That is why you are cutting at the superior aspect, so that you will minimize the damage without injuring the nerves. Okay, so because nerve supply is below upwards, that is the reason. And at this junction, the examiner will ask you what is the nerve supply of strap muscles. So I told you there are mainly four important strap muscles: thyroid, omohyoid, sternohyoid, sternothyroid. All these muscles are supplied by ansa cervicalis, except thyrohyoid, which is supplied by hypoglossal nerve along with the cervical plexus. This is the exception. Okay. So ansa cervicalis will be supplying to these muscles from below upwards. That is why you are cutting if you require. You will cutting at the strap muscles at the superior aspect. Okay. Right. So once you open the pretracheal fascia, you are encountering the thyroid gland. The first thing, the first vessel we are ligating is middle thyroid vein. So middle thyroid vein ligation. Let's say for example we are going to do hemithyrectomy. You will go on that side. Middle thyroid vein is ligated and divided. After that you will go for superior pole ligation, because 80% of the blood supply around will come from this superior pole, superior thyroid pedicle. So superior pole or superior pedicle ligation and division, then followed by inferior pole or pedicle. Once you deal with the superior pole and inferior pole, the next important maneuver you are going to do is something like a, you will gently medialize the gland, medialization of the gland, medialization of gland, where you are encountering something called Berry's ligament. So at the level of Berry's ligament, we need to be very careful, because it is one important landmark where you can have recurrent laryngeal nerve. So once you excise the tissue at the level of Berry's ligament, then you divide or ligate the isthmus. Okay, then you will remove the specimen. Okay, we will see important aspects at each step. So this is the basic step. Now, one important question they can ask you is, whenever you are ligating the pedicle, superior pedicle or inferior pedicle, please understand you should always go at the mostly near to the gland. Means whenever you are dealing at the superior pole, you know from the diagram you can see here, EBSLN, external laryngeal nerve, is present at the in the vicinity of superior pole. Okay, so that is why when you are dealing at the superior pedicle or superior pole, there is an important maneuver called Nyhus maneuver. What are you doing? What are you doing here? So please understand, this is the superior pole of thyroid gland. To visualize something called Joel's triangle, that's where your external branch of superior laryngeal will be there. So it is nothing but your EBSLN, external branch of superior laryngeal nerve. To expose the EBSLN, you are doing a maneuver which is nothing but you are gently holding the superior pole of thyroid, and you are pulling it gently down and out, inferiorly and laterally. When you do this maneuver, you will visualize this Joel's triangle, which is bound by, so you can see here, superiorly you have got strap muscles, and superior pole of the thyroid and superior thyroid vessels laterally, and midline in the medial. So these are the boundaries of Joel's triangle. This is another important point that they can ask you. So the name of the maneuver is Nyhus maneuver. Undergrads, don't worry. PGs, it is very important for PGs. So the name of the maneuver is Nyhus maneuver. This space is called space of Reeves. Again, important for only PGs. Space of Reeves. It is the avascular space between your superior part of the thyroid gland, and also this is cricothyroid muscles. This is cricothyroid muscle.